What are some of the symptoms I might experience with a low testosterone level?
More body fat, less muscle mass, less energy. But we do know that many different symptoms, including depression, can be a symptom of low testosterone.
Dr. Kyle Gillett is a board-certified physician who's redefining hormone health by helping men and women optimize mood, fertility, aging, and performance through science-backed personalized care.
The first pillars are diet and exercise. The other pillars I did alliteration: sleep, stress, sunlight, and spiritual health.
What could be some of the signals that you can endure that will indicate, hey, there might be something to look into?
One very common symptom is...
Welcome to a new episode of Hack You. Today with Kyle Gillett, MD, dual board certified physician in family medicine and obesity medicine. We cover everything from thyroid to hormone optimization, TRT, when's the right place to start, what alternatives are there, including peptides. There's a lot of statements being made that I think are going to make you think, including how sometimes a low dose of testosterone over 50 years can have much greater benefits than the standard dosages TRT clinics prescribe. It seems like almost every day nowadays. Hey guys, welcome to a new episode of Hack You. Absolutely excited to have Kyle Gillett here with us. Kyle, welcome, and thank you for actually joining us today.
Thank you, my pleasure.
Kyle, the Hack You community is a community of people who are looking to optimize themselves, who are maybe not at the stage of their life where they think they need support, but they're already thinking about what they would start with if they would get to this point. Now, when we look about optimization, the two main things that people are always talking about is thyroid and hormone optimization. In terms of hormone, I mean sexual hormones. But before you think and realize that you need to optimize, what could be some of the signals that you can endure day to day that will indicate, hey, there might be something worthwhile to look into?
Yeah, this is a great question because a lot of people say, well, I'm healthy, I don't need to go to the doctor. Or a lot of males specifically say, well, I haven't been to the doctor in 10 years and my partner, my wife, made me go to make sure I'm fine. But then you go to your regular doctor and you get really a very poor lab panel and everything is quote unquote normal. And, at the end of the day, we're just organic machines. So I'm very analytical about this. If you have a car and you want it to be a classic car that you can drive for quite some time, then you're probably going to take very, very good care of that car when it's 3 decades old, 4 decades old, 5 decades old. There are Ford Model Ts that are still driving around, but none of those have been heavily abused or even used in the wrong way. But we're kind of like a car in that if you have a classic car, people know that, and I'm not a car person, by the way, but you know that you have to go to your car and at least a few times a year turn it on, because if you don't run the engine and use it, that's also bad for it. But anyway, you don't go to Jiffy Lube. You don't go to a place to get a regular oil change to take care of your classic car. You go to a specific type of mechanic, a race car mechanic, a collector's car mechanic that is very specialized. And you say, I don't think that this car is running as fast or as well or as smoothly. I don't think it's steering as good as when it was brand new. So often, if you look at professional athletes or even if you look at people's brain sizes, they're already shrinking and the performance is already decreasing in the 30s. And then it's just a process like any other medication. When you're talking about thyroid optimization or hormone optimization, what are all the risks and benefits for each individual?
So when let's say I don't have the spouse who sends me to the doctor, quote unquote, what are the symptoms that in everyday life, when I potentially might have thyroid issues, would I realize? Is that something where my hands get cold, or is that something where, from a weight management perspective, what are some of the symptoms that you see people complaining about and you as a doctor like, oh, this might be something thyroid related?
It can be. One very common symptom is more hair shedding when your thyroid is low. Or if your thyroid is too high, then fast heartbeats, feeling warm all the time. But it's also common to have a thyroid that is borderline or subclinical hypothyroid. We call that euthyroid 6 syndrome now. It's common to have no discernible symptoms at all. Some people will get a test and it's slightly abnormal, and then in hindsight, they notice symptoms. But people should watch out for cold extremities, hands and feet. They should also look out for weight changes, hair changes, skin changes. They should also look out for heart rate changes.
When you say skin changes, more dry skin?
Yeah, dry skin, or even changes in, let's say, the amount of atopic or eczematous patches they have. A change, if you're predisposed to rosacea, a change in that. So it doesn't necessarily have to be just dryness of the skin, but they should look out for that. And then also mucosal membranes to see if their mouth or their eyes or any other mucosal membrane really has significant changes.
So okay, so let's say I have experienced those symptoms, and I'm like, you know what, I want to get the panel done, and I want to come to the doctor already with a panel to get ahead. What would be some of the parameters that would check for that for you as a doctor would be critical to make the first assessment?
Yeah. So if you go to your typical doctor, a lot of times they check just a TSH, which is the hormone that comes from your brain that goes to your thyroid to stimulate thyroid hormone release, thyroid stimulating hormone. And if this is high, then it means that your brain is trying to tell your thyroid, produce more hormone. But there's also your main thyroid hormone, T4, and your active thyroid hormone, T3. And I think that these two should also be checked. And then in some cases, you also check a reverse T3, which is the type of T3 that's not active in many tissues, other than tissues that shut down thyroid hormone replacement. So there is an important role for reverse T3. But these things are often checked, and then if those are abnormal, or if you have a high pre-test probability, which just means you're very suspicious, then you can test things like thyroxine binding globulin, which is a protein that helps control metabolism and action of T3 and T4, and then also your various antibodies against thyroid tissue. But I would recommend, even if you're only concerned about your thyroid hormone, or your, let's say your hands and feet are cold all the time, even though it's very hot outside, then people should also check a testosterone and an estradiol, because testosterone actually helps increase the amount of free thyroid hormone, but it speeds up its metabolism. And estrogens like estradiol do the opposite, where it decreases the amount of free thyroid hormone, but it also slows metabolism. So that's why a lot of times you see, especially females, started on estrogen only, whether it's a hormonal contraceptive or bioidentical estrogen. And that's going to decrease the amount of free thyroid they have. And then a lot of times they develop thyroid symptoms after that.
Speaking of men and women, would the test be the same for both in terms of the parameters, or would you add something maybe to the women?
It'd be slightly different. With premenopausal women, you do not have to do as sensitive as an estradiol. So males and women after menopause, or women on hormonal contraceptives, where you expect an estradiol level less than 50 picograms per mil, that's how they almost always measure it. So less than 50 expected, then you need a sensitive estradiol. Whereas the usual estradiol you have, that costs $4 or $5 instead of $50. That, if you go to what I call a self-service lab company, if someone's trying to sell you labs, they're going to sell you the cheap estradiol. So if you're a male, then you want to get a sensitive estradiol. That way it's actually accurate, and it is not going to have a falsely high or falsely low number. So you'd also want to see when in the cycle the female is, because if you're going to check it between day 21 and 24, you can add a progesterone. But if you're going to check up a peak level, maybe around day 14 or 12, then there's no reason to add a progesterone, because it's not going to have been increasing. So it does matter when to get the labs as well.
The one thing I was very happy about is I've been testing on and off for 7-8 years very regularly. And just recently I was told to do a reverse T3 parameter check. And I want to understand, how does maybe training or low-carb diet impact that? And what do I learn from this?
Yeah, so T4 can be basically they can remove an iodine in several ways. There's an enzyme called deiodinase, and there's a 5' and a 3' iodine spot. And this doesn't necessarily matter for like the layman, but what you can remember is think of it kind of like a right-handed and left-handed molecule. They're not true enantiomers, but the reverse T3 is so similar to T3, but it just can't quite fit the receptor that's in tissues like the heart. So it's not going to speed up the heart, and it's not going to, help burn fat off the liver. However, it is going to be very active in the hypothalamus and pituitary. So it helps calm down thyroid hormone production, which is why it's really useful in cases when there's too much T3. So basically, if you have a many dietary inputs matter. For example, the amount of iodine you have in your diet is going to matter, the amount of selenium, even super high amounts of biotin, which is a B vitamin, can induce a hyperthyroidism. So it can increase free T3 and to some degree reverse T3, just not as much. So the ratio is more what it matters just as much as the absolute number. But selenium and mercury are particularly important because selenium is the cofactor or the catalyst. And the catalyst basically means it's easier to convert from free T3 to free T4. And then mercury blocks this coenzyme and actually almost all coenzymes throughout the body.
So let's say, okay, I would come in, I was diagnosed with hypothyroidism. And then I'm like, okay, what now? And what is the starting point? What do you start with? And what's the levels to this? So I remember that you did recently a podcast. You talked about the iceberg, about the things people know, and then the things that people think they know, and then the things that they have no clue about. And what do we start with? And how often would you check on the person if what we're starting with actually is working?
So for hyperthyroidism, there's several types of hyperthyroidism, but Graves' thyroiditis is a very common type. And you can have seropositive and seronegative. So this is what's above the ocean surface, what's well known. Let's say you have your heart is racing, you can't sleep, you're sweating all the time, you're very warm, and you check a free T4 and it's a 4.0, which is very high. You check a TSH, and normally, this is a classic case, TSH is very, very low, so it's suppressed. So something else might be causing your high thyroid levels. And, you might be referred to an endocrinologist, and they make sure you're not in what's called thyroid toxicosis or thyroid storm, because you don't want to get AFib, for example. So a lot of times they manage this just with beta blockers, like propranolol, which can help you feel a lot better. But unless it's very high, they generally don't need to start anti-thyroid medications, which are methimazole and propethyluracil. And basically, these two cause free T4 to pretty much just be converted to reverse T3. And they prevent conversion to free T3. So usually you don't start these unless you think things are going to get worse. Hyperthyroidism classically presents after miscarriage or delivery. So it's very common after pregnancy states. But yeah, that's what's above the iceberg. What's slightly more below the iceberg is part of what I already mentioned, is there's a lot of medication or even supplement-induced hyperthyroidism states. So if someone's on a very high dose of biotin, or if someone's on taking too much iodine, then these should arguably be scaled back. And likely the same case for selenium. So I have people pause their Brazil nut consumption, and that's important. And then far beneath the surface for hyperthyroidism is if it's seropositive, seronegative, which some people don't care about as much. And then if you're going to get RAI, which is radioactive iodine ablation, or if you're going to get surgery for this hyperthyroidism. So there's a whole bunch of different risk and benefits, and there's an argument of its correlation or causation with longevity, the number of years that you live, and whether or not you have osteoporosis. So there's certainly a lot of controversy that's not in what I'd consider the standard of medical treatment.
But as a male, you would avoid the mercury. Your iodine consumption should be high. Your selenium consumption through Brazilian nuts or something else. Other supplementation, there's all those thyroid supplementation. When you look at it, they're like, what does it mean? Can you overconsume? What's the danger behind that? And again, when do you test and what do you test and what regularity to understand if this is the right way to go?
With hypothyroidism too low, every 3 months or so is reasonable once you're on a good regimen, depending on if you're going to do replacement or not. With diet, it's all relative. So I would say a normal or an optimal amount of iodine, you definitely don't want too high. But if you're not consuming a lot of iodized salt, then your diet would likely need to be quite high in iodine. So there are good brands of salt. I understand people that want to get salt from good sources and this and that. But I do think that it is very reasonable to consume a lot of the iodine in your diet via salt. Selenium, same thing. It is possible to consume too much. I would say no more than 2 large Brazil nuts per day, but this is on an average of 365 days. So even if you have 15 Brazil nuts one day, I don't think that that's a health concern for the average person. And then I believe you also asked about mercury and other nutrients. There's a lot of thyroid support supplements. Many of them have ashwagandha in them, which can be helpful for some reasons, and I'm not against it, even though it's very trendy to be very anti-ashwagandha, anti-lion's mane. They should just be evaluated same as medications, talk about risks and benefits. But in general, I think that a nutrient support or just a very good multivitamin is going to be just as good as these various thyroid support supplements that have L-tyrosine in it, because that's the amino acid you make thyroid hormone with. So yeah, in general, for people that want to make sure that they're getting all their nutrients, good multivitamin or a thyroid support supplement. I know Designs for Health has one. It's basically just a multivitamin.
Understood. So hypothyroidism, selenium, iodine, supplementation, ashwagandha at night. I heard you, ashwagandha should be taken closer to bedtime to not impact your adrenaline spike in the morning. And then you test around 2 to 3 months to understand if the approach is working. There is this field of bodybuilders that are adding to their supplementation T3 and T4. Can you explain the thought process behind this, what they're trying to achieve, and what's the downside, of course, is always with them, because they're quite extreme in what they're doing?
Well, I'm sure they're trying to treat their fatty liver disease, right? Just kidding. Well, maybe some of them. There's a recent medication for fatty liver disease that binds thyroid receptors, mostly just in the liver, that actually looks fantastic. So thyroid optimization does likely help decrease VAT, which is visceral adipose tissue that's inside the abdominal cavity in the liver. You think of a ninja turtle gut where you have shredded abs, but you have a bunch of fat inside your abdomen. So there is potential benefits for bodybuilders that are supplementing with that extra thyroid hormone. One interesting benefit of thyroid hormone that people know about, that it's slightly more fat burning and gives them a little bit more energy, but it also helps increase SHBG, sex hormone binding globulin. So for enhanced bodybuilders that might be on a lot of androgens or SARMs, which just selectively bind the same receptor as testosterone, then it does help stabilize the level of those androgens in the body.
Understood. Now comes the topic that everyone in the world, from the US to the UAE to Dubai, everybody's talking about. And it has a certain stigma, but it feels the stigma is shifting. So we're talking about HRT and everything around reproductive hormones. And there's this thing that literally, and you were on stage a couple months ago and you said, hey, whenever we prescribe birth control to teenage girls, this is the first wave of hormone treatment. So whenever we talk about HRT for grown men or women, and we have the stigma attached to that, we need to understand we've been doing this for a long, long time to teenagers. Can you start with this a little bit, just so we set the foundation from a doctor's perspective, what HRT is and how the world should respond to it?
You want to make sure that the patient and or their guardians, parent or guardians, are understanding, and you're not making them do something or making them not do something, you're coming to that decision together, because at the end of the day, it is that person's health. But the big problem I see is that people say, well, I don't feel comfortable prescribing bioidentical hormones, but then they feel way too comfortable prescribing oral contraception.
Absolutely. So there's this whole narrative that testosterone drops by 1% after 30, and is also dropping now quicker than ever before. From your perspective, from the medical side of things, what's the explanation behind this? Are we living longer, or is there something going on in the environment? What's happening?
If people try to think about every single thing, then it can be relatively overwhelming and actually lead to paradoxically worse outcomes in people who have some of the healthiest lifestyles, because you can't, don't live glass half empty. You want to live glass half full. And even if the glass is only a quarter full, you want to live glass quarter full. The medical advancements that we've made, like you mentioned, have, in spite of all these things, been prolonging lifespans in healthy people. The reason why lifespans have appeared to start to decrease is just because people are very, very unhealthy, which is why my statement, the lifestyle interventions, the pillars of health, are the most powerful things you can do for your health, more powerful than any medication or supplement. I plan to stand by that, and I just think that it's true. And if everyone did that, then perhaps our average life expectancy would be 100.
By the way, I would love for you to share a bit on the pillars, because I can tell you on personal experience, when I heard your pillars for the first time, I'm like, come on. I mean, yes. And then you're like, actually, especially there was one pillar, I'll let you first, that hit me when I realized how right you were, because I never considered how much impact it has on my psychic and the psychic has on my well-being. But if you can explain to our listeners from what are the pillars and why are they so essential?
Yeah, the first pillars are diet and exercise. The other pillars, I did alliteration, so I used S's. And those are sleep, stress, sunlight, which just means being outdoors. It encompasses cold and heat exposure. It encompasses natural light. And then spiritual health, stress, if I haven't said that yet. And then the one that I added latest after everything that happened in pandemic is social health.
Mm-hmm.
So there used to be 6 and now there's 7. And, there's not a perfect optimal way to do these pillars. For example, some people do better if they actually increase the level of their stress, but learn to adapt to it. Some people have bitten off too much, just like trying to lift too heavy a weight, and they do better decreasing it. Most people need to emphasize their diet more, but some people are orthorexic and they hyper-focus on only healthy foods, and maybe they'd be better off going by, an 85% or 90% rule and then having 10 to 15% flexibility. Because the best diet's one that you can adhere to.
Yeah, your statement was there is no treatment out there, there's no medication out there that will ever beat the pillars, because the pillars has the biggest impact on your overall health.
Yeah, the pillars are the actual act of improving your health. And then any sort of pharmacology, whether it is a medication, a peptide, a supplement, that is just the supercharger or the turbo to help those interventions work better.
Awesome. The one pillar that I had to think about was the spiritual one, because I never thought of myself as a spiritual person. But when you brought the example that if something bad happens in your family, if somebody passes away or something tragic happens, how you feel afterwards and what you also physically start feeling, I realized how much sense that makes, and I started applying this also a little bit to my own perception.
Yeah, great to hear. I try to say these things with as much applicability for everyone. I happen to be a Christian. I don't think that that's necessarily. I don't put Christianity as the pillar of health. I put spiritual health, which is the same thing as metaphysical health. For some people who are analytical like myself, certainly it's harder. So this is a downside to being analytical. I feel like a robot that's put into a human body sometimes. But if you have that same predisposition, then just think about your metaphysical health and your meaning beyond this life. Whenever I bring up Maslow's hierarchy of needs, there's somebody that says, read this book and read this book and read this book. And I've read some of them about how it's not perfect. But at the end of the day, I do think it's important to realize that your physical needs and your mental needs and your metaphysical needs are somewhat stacked together to where you do need pieces of each of those. Otherwise, they start to crumble.
Absolutely. Now, let's also do the same exercise. Before I go to see the doctor, what are some of the symptoms I might experience with a low testosterone level?
Yeah, now these can be widely variable, and they're actually slightly different for males and females. For example, with males, low libido is arguably more common, and the complaint of changing body composition, more body fat, less muscle mass, less energy is also more common. Whereas with females, a lot of times it's in hindsight. If the testosterone's low, or even if the free testosterone's low, but the total testosterone's normal, then a lot of times they don't notice the body composition changes or libido improvement until after they begin therapy. But before you go in, I think that it's also important to think about testosterone as a hormone that makes effort feel good. And that effort includes lifting a weight. That's kind of what I call ergogenic effort. And it's also effort that is in other things. So yes, there's some dopaminergic or motivation benefits to androgens like testosterone in males and in females. But what you can notice can be pretty widely variable. It used to be that the academic societies said that the main symptom to look out for was low libido and improving testosterone levels, even according to the American Academy of Family Practice, was reasonable in order to improve this. But we do know that many different symptoms, including depression in males and females, can be a symptom of low testosterone.
When you say low libido, just as again, from daily applications, is a morning erection a sign, or the absence of it, a sign of low testosterone, or is that something else?
It certainly can be a sign of low testosterone, but it can also be a sign of plaque, plaque throughout your arteries. And it can also be a sign of poor vasodilation or poor sleep. But yes, that's certainly one thing to keep an eye out for. Keep in mind that you're most likely to have morning erections if you're waking up naturally from a REM sleep cycle. So, for example, you're slightly less likely to have one if you wake up at a time in your sleep cycle where you're not normally going to have an erection.
Okay. Now, by the way, quick point. You said that with a higher testosterone, weightlifting or higher activities or difficult activities feel better. That would explain why people who work out a lot of bodybuilders who are on TRT or even more than that have different workouts with more reps, more sets, smaller breaks. Is that the connection there?
Yeah, to some degree. Another reason for this is, higher androgens is going to, in general, increase muscle protein synthesis. And a lot of times, if you take things that help block the glucocorticoid receptor or the receptor that cortisol binds to, then you can have decreased muscle protein degradation as well. So there's physiologic reasons and mental reasons. But a lot of it is mental because you see some bodybuilders or individuals that get very lean and their testosterone. I've never seen an actual natural bodybuilder pre-show. I've seen a lot of pre-show labs. And even for very healthy people, testosterone is always very low, partly just because of the huge caloric deficit. And they're so lean, so low body fat that it is not healthy. And some of these individuals are still able to push through the workouts, but they will tell you that there is pretty much no erections, nocturnal or otherwise at all, and they have no energy. And although they, suffer through the workout, they're on the couch the entire rest of the day. And this is still true to some degree for enhanced individuals. And by the way, I would consider even someone who is on, HCG or Clomid or pro hormones or SARMs, they're still enhanced. I mean, it's just slightly easier. So it's still very difficult regardless. But it is a one benefit for people that are, I guess you could argue if you're a professional bodybuilder, maybe it's necessary to feed your family because that's how you make money. But that is one potential benefit for particularly parents or people that have shift work to where their sleep is going to be so terrible that it is going to affect their testosterone. It's something to keep in mind.
Now, back to the real world from the bodybuilding world. I'm 30, 40, male. I have the symptoms we just discussed. Where do I start? What's the starting point? We have all those ads for all the testosterone booster supplementation. We have all those things, TRT clinics popping up. What is the right first step to take, and where do I take it forward?
Yeah, well, the typical answer to this, if you go to what I consider a cookie cutter clinic or telemedicine clinic or, functional clinic, is if you're under the age of 35, they put you on Clomid or enclomiphene. And then if you're over the age of 35, then they put you on some random HRT protocol, whatever makes the clinic the most money. And I'm not trying to sound overly cynical. This is just how things kind of have previously been. And fortunately, there's individuals like Derek, who has his More Plates, More Dates channel. And there's Andrew Huberman. And there's other people with much larger voices in the community than myself that talk about the benefits and the risks of things like Clomid or even HCG or, testosterone and how it could be done subcutaneously with multiple injections per week. But the first step, in my opinion, is actually just to write all of this down. Places will have a questionnaire about whether you're having these symptoms or not. There's actually a very good article about discordant guideline-based care in telemedicine clinics. Dr. Fantis from the University of Kansas was one of the authors, and it has a great graph or table. I could send it to you for curious listeners, but it has a table that shows the questions that were asked and not asked. And this individual was just the same as you described, between 30 and 40 years of age, and only one clinic asked him about future fertility before starting him on various conglomerates of peptides and hormones. But after you write these down, then you have a list, and then you go to somewhere to get your labs. I, of course, have my companies, which I'm very biased for, but I think we have the best prices, and people can, at least residents of the United States, can go to sagebio.com or gilletthealth.com. And even if you're not a resident of the United States, you can also go to sagebio.com and you can see all the biomarkers that I recommend depending on what gender and age category you're in. And then you can start with these labs and then go to a physician or nurse practitioner that has adequate expertise. And people say, well, my general practitioner is not going to know how to interpret these labs. So I say, well, if you were in, like, let's say you're getting a patent, would you go to a family law attorney in order to discuss that contract patent? No, you would seek out a contract lawyer. So go to a reputable physician that you trust and that you can ask questions to, and they won't blow you off. In general, my green flags is if they charge you for the actual advice they're giving you and they don't make any margin or money off of peptides or medications. And then if they have at least 30 minutes, I have an hour per patient visit or more sometimes for concierge patients. But I think it would take at least 30 minutes of actual discussion in order to kind of parse out all the benefits and detriments of whatever intervention you choose to do, including non-medication natural interventions.
Do you think, again, anecdotally speaking here, clomiphene before 35 and injection after 35 is because one is oral and it's easier to intake, and then the 35 is more for the responsible people who are more adults? Do you think they just made that the cutoff point for that?
That might be a factor, but I think the main factor is that a lot of prescribers, a lot of healthcare providers are hesitant to prescribe testosterone to people under a certain age, because in the past, various boards have wanted to re-educate providers because they're over-prescribing, which, to be fair, I don't know the situations or whatnot, but I know of cases where this has happened. People may have been over-prescribing. testosterone to younger ages, and testosterone is a controlled substance, whereas Clomid and Clomiphene are not controlled substances. So I think the barrier to entry and also just the comfort level of the healthcare provider, a lot of them have great interest, but a lot of them there's no great go-to education outside of textbooks. But many of them have not been trained in the way that would be optimal to be trained. I'm working on this with a variety of organizations, Metabolic Health Initiative, Longevity Docs, Scale, etc. But I think, that the main driving force is that healthcare providers are just scared to start younger patients on that. And the other reason is people have showed up at a clinic and they want something. They don't want to leave empty-handed. And I think a lot of young people are tricked because when you take Clomid or Enclomiphene, you might not feel any better. You might feel way better on something like Jitinzo, but your number goes up. So you're happy that the number went up and you feel like they at least did something.
Yeah, and the side effects might actually not be, or maybe even worse than with a, regular injection of a lower dosage of TRT. From a TRT perspective, because you just said about fertility plans for the future, is there a world, and I'm going to use this, the word hop, can you hop on TRT and hop off and stay fertile for the future? Is that something you can do to get back in shape? Is that something seasonal? Or is this once you start it, that's your go-to for the rest of time?
Yeah, you can start and stop. And in general, when you stop, if you recover adequately, which 99.9% of the time you do, then you will regain your previous level of fertility. Interestingly, you might not regain your peak sperm count. In some cases you do, but you at least regain the amount of fertility that you had previously. So you can go off and go on, but a good rule of thumb is unless you are truly hypogonadal, I don't think it makes sense. If you're borderline hypogonadal and you have pretty severe symptoms, then it can make sense. There's always exceptions, but a good rule of thumb, unless you are hypogonadal, clinically deficient in testosterone, the benefits of classic testosterone replacement therapy, even if it is, temporary, often don't outweigh the downsides of trying to improve your testosterone in other ways. And ideally finding the root cause and correcting it if that's possible, and then waiting until after your fertility window to be slightly more aggressive.
You made a statement that kind of opened my eyes. You said that actually TRT in a lower dosage might be more beneficial to your health if it allows you to reduce your visceral fat or just lower your obesity, because then the overall health improves even though it's exogenous TRT. Can you just maybe add a little bit to this?
Yeah. There's a difference between true replacement testosterone for injectable doses. Let's say you're on testosterone cypionate or testosterone enanthate. A true replacement dose is somewhere between 70 and 100, maybe 120 milligrams. Now, often the benefits of a slightly higher dose, like 140 milligrams or 150 milligrams per week, outweigh there is significant more benefit over taking 70 mgs, but a low dose is going to have exponentially less side effects if you're predisposed to a side effect. For example, if you tend to get high blood pressure, of course, there's a lot of other things that you address too, but it's going to be much more likely if you're taking 200 mgs per week compared to 70 mgs per week. The same thing if your blood gets too thick, which we call erythrocytosis. So you still get a lot of the health benefits, and there's pills that are essentially the same thing as oral lymphatically absorbed testosterone undecanoate. Jitinzo is my favorite because Jitinzo is often free and covered by your insurance. So, this is also studied specifically for fatty liver disease. And I think that a lot of people are not looking at the health reason itself as the big benefit. They look at the symptoms, which is okay, but it's important to discuss, both what the patient cares about the most and also just keeping their organic machine as healthy as possible physically.
I think you're the first one who publicly, that I heard at least, said something between 70 to 100 milligrams, because the cookie cutter TRT clinics sometimes even start at 500. So that we're even talking below 100 range is interesting. Now, that low range, could this be considered part of a longevity protocol for people in the future? Is that something that could be part of quote unquote stack?
Yeah, it could be. Personally, I would rather take, let's say, the last 50 years of my life, I'm taking 100 mgs per week. I would much rather take 100 mgs per week for 50 years than take 200 or 300 mgs per week for 20 to 25 years and then have to stop because of some cumulative damage it's done with the liver, the kidneys, or the cardiovascular system. You're going to get a lot more prolonged benefit and quality of life, especially much later in years. For both males and females, there's no age cutoff to when you have to stop HRT. So that's another thing to keep in mind. Are you training to have a 5 more good years, like a lot of bodybuilders seem like they're training? And that's somewhat changed. Bodybuilders are way more health focused now than they used to be. I know that Aegis Nutrition, which is David and Caroline De Mesquita, and many other bodybuilders, and Derek from More Plates, More Dates. He also talks about bodybuilder health as well. There's merit to building your body, but I just think that they're the perfect example of people who, especially when they're younger, often way short-sighted in terms of they feel like they're going to live forever, and the machine actually breaks down pretty quickly.
Before moving on to the fertility aspect, the one thing that is a lot of discussed and also feels a bit like advertisement, there's this noise around bioidentical and synthetic testosterone. Is there a benefit to either one of them?
Yeah, so this is a great question. There's kind of a few classes, bioidentical and non-bioidentical. So an example of a non-bioidentical, which would be oxandrolone, which is basically just very small doses of oxandrolone, which is Anavar. And, it's been studied in things like Turner syndrome and other conditions, but that's an example of something that is not naturally in the body. Testosterone, of course, is bioidentical. Interestingly, nandrolone, which is 19-nortestosterone, is technically bioidentical. Some people know that one is DECA, but it's in such small quantities that I don't really put it in the bioidentical category, even though it's technically bioidentical. So there's also a difference between synthetic and naturally occurring. So some testosterone is made from yams, and you can make testosterone from different plants, and it can be somewhat naturally derived, but it still does have to go through a few steps of synthesis after that. But our process of making testosterone is good enough that I don't care if it's completely synthesized as long as it is the exact same bioidentical molecule, which it often is. In our body, there's a ratio of testosterone to epitestosterone. And when you're on replacement, you're not going to replace that epitestosterone. So you can do blood tests and see, are you truly on replacement or not replacement? But at the end of the day, the pro of bioidenticals is that we know a lot more about them because they are at least naturally synthesized in our body, and we can replace it with the exact same molecule. That being said, when you have a cypionate or an anthate ester, yes, you cleave the ester off. But a lot of these esters, for example, propionate is also made in our gut by our gut microbiome, so it's very naturally occurring. So I'm not scared off by esterified testosterones. That being said, there are unique benefits to synthetic versions as well that are not bioidentical in the body. A good example of this for some females is drospirenone, which is a type of progesterone that actually blocks the androgen receptor for women with very high amounts of androgen and other testosterone and other androgens. And it also is derived from spironolactone, which a lot of women are on anyway, which I try to get them off if they don't need it. But there are time and places, even for synthetic hormones, that are looked at as contraceptives that you can use for other reasons.
One question that I hear, men who want to start HRT, they're saying they're scared of cancer. Is there a link? Is that something that was just, is there just bad press out there to try to keep men away from it? What's going on with that topic?
Great question. So, androgens certainly do grow prostate cancer if they're delivered to the prostate. So, if you have a aggressive prostate cancer, then I certainly wouldn't take an androgen. But most of the other risk is just correlation and not causation.
Understood. Bless you. On HCG, so a man who's wants to start TRT but still wants to keep his fertility is recommended to start in parallel HCG. Do I understand correctly that yes, you keep your fertility throughout and you still can get your spouse pregnant, but if you wouldn't take HCG, that testosterone would be more efficient?
It's a good question. So even without HCG, most males are still fertile for at least several months, and it actually takes a couple months for testicular atrophy to begin. And depending on your dose, you can also be more or less fertile. So if there's someone who is on, let's say, they're on 30 mgs 3 times a week subcutaneous, they're relatively likely to still have FSH and LH naturally produced, some, and there's a good chance that they have some sperm count. It's not going to be as high as it was previously, but I have seen many children conceived while someone's on just TRT without any HCG, so that's quite common. And there's ways to test for this and minimize it or maximize it if you want to, but it's TRT should not be looked at as a contraceptive. That being said, if someone takes HCG, they are usually fertile, but depending on the dose of the HCG and the testosterone to some degree, and how long they've been on it, then fertility can drop off or start back up. If there's someone who's on for 10 or 15 or 20 years, they might consider something like FSH, because FSH is going to help with the spermatogenesis process quite a bit as well in a unique and different way than LH does. In fact, FSH is often more helpful than LH, and HCG does bind just the LH receptor and actually also the TSH receptor on the thyroid as well.
Can HCG in a higher dosage, or does dosage matter, have a direct impact on prolactin levels or increase of prolactin levels? Is there a direct correlations between that?
There's certainly a correlation, but it likely has a lot to do with just increasing estradiol levels. Anything that increases estradiol as it binds to the estradiol receptor, that's going to directly increase gene transcription at the PRL gene, which is the prolactin producing gene for synthesis. So it can have that effect.
So it's more
That
the
being said-
testosterone. It's more from the testosterone.
Correct. HCG in general, especially if someone is not on a very high dose of testosterone, HCG will cause more testosterone production as well. And if people are worried about gynecomastia or sensitive, itchy, and swollen nipple area, glandular breast tissue, then HCG and almost anything else, including testosterone, including DHEA, and including FSH, can lead to those symptoms.
One interesting question that was asked recently, as a woman, so there is the understanding that postmenopause TRT might be an option or interesting. Are there potential health benefits to start it before your menopause as a woman?
Yeah, most of the same health benefits as starting after, especially because progesterone and testosterone and also growth hormone tend to decline before menopause. At menopause, the main thing that does is estrogen. But, with classic menopause, then a lot of physicians are going to want to wait at least 6 months to when you've had no menses whatsoever and you've had very low estrogen levels in some cases, or when your FSH is very, very high. So you can, save yourself some suffering during that time by starting bioidentical hormones before. And I would say for the average female, if they have low DHEA sulfate, they're going to be more symptomatic in menopause and perimenopausally, and they are better off starting at least some hormones before they go through menopause. The main downside of this really is not that it increases their risk of side effects, because in these young ages, for example, age 50 or age 45 or even age 40, the risks of the hormones are actually way less than in much older ages. But it does make it slightly confusing. Let's say you put someone on some physiologic HRT to where they're still cycling, then it's hard to tell if it's still a true menstrual cycle. Let's say they're on it for 3 years from age 50 to 53. Is that a real menstrual cycle, or is it just induced by that physiologic HRT that we have the person on? And for some healthcare providers, that is very daunting, trying to parse that out and kind of saying, yes, you are now in menopause. Because the ovaries, when they get a rest, often have a second wind. So it is very complicated, which I very much enjoy. But my frustration is that when you go to a doctor that is willing to prescribe you for hormones, I think it's great that we have a lot of them. Most of them are actually OB-GYNs or functional med docs that never prescribed hormones their entire career, and then their wife or themselves went through menopause, and then their life was completely changed when they started hormones, which I think it's great that they've completely changed their career and practice style. But what I don't think is great is most often these people just prescribe all their patients the exact same regimen that they themselves or their spouse took. So there's a huge gap. And part of this is just because ACOG, which is the Society of Gynecologists, doesn't have great recommendations. AACE, which is the endocrinologist, doesn't have great recommendations. AAFP doesn't have great recommendations. None of them include testosterone as part of their recommendations. And in my opinion, at least half of women can benefit from some sort of androgen in a very appropriate dose. Most people who prescribe testosterone to females, that's too high of a dose. But at the right dose, it can be hugely beneficial. But yeah, the problem is that people just don't know how to individualize that regimen. Part of that is because some of what we've gotten from males is from the bodybuilding community. Again, like Derek, more plates, more dates. When I started, helped start Merrick with him 4.5 years ago, whenever it was a huge leap forward in both optimization prescribing for GLP-1s and HRT. And some of the protocols that they came up with were great. And we still had some of those same protocols we did have those same protocols for females, but for whatever reason, more males, I guess, watched YouTube, more plates, more dates than females, and it has not kind of gotten into mainstream society. Big conventional medicine academics has still kind of controlled this, and they basically just, these famous, I'd call them hormone influencer doctors, they just push the same regimen that they took. So when you're listening to a doctor, whether it's a male or a female talking about women's hormones, think, is she just talking about the HRT regimen she took? Or is he just talking about the HRT regimen that his wife took? And is this really right for me?
Thank you. Speaking of regimens, there's this one big word that is global. Everywhere I go to, everybody discusses it. It's peptides. So what is your stance on peptides, and why do you think this is becoming such a trending word right now?
Yeah, I think there's several reasons, but the first one is a lot of them really work and they help quite a bit. And that is a good reason that it's trending. And many of them are bioidentical hormones. So many of them are very similar. They're very biosimilar hormones with just one or two amino acids different. GHRPs like tesamorelin and CJC and sermorelin and pralmorelin are like this. And some of them like BPC 157, very similar to, it's essentially just gastric protective compound 157. So I think it's very reasonable to incorporate more bioidentical hormones. They're just peptide hormones. For example, insulin is a peptide hormone, like completely life-saving, has saved, countless lives since it was introduced for diabetics that would have died otherwise if we hadn't found that insulin peptide. So, there's a lot of reasons to do them, but they should be approached just like medications. Again, talk about the benefit, the detriment, and talk about the evidence or lack of evidence. So that's what we do on the Gillett Health podcast, is say, hey, yes, this is an FDA-approved peptide. It works great. Here's what its limitations are. We're concerned for tumor growth, cancer growth. It binds glucagon strongly. I'm kind of concerned about retatrutide because people think it's so much better than other GLP-1s, but I wouldn't want something binding glucagon receptors throughout my body at very strong levels indiscriminately when I don't necessarily need that, because that is going to cause so much growth hormone release that I think it's going to lead to the same side effects of growth hormone and tumor growth. So lots of things to keep in mind with peptides. I think the one thing that, and in general, I would say I'm 99% pro peptide. You can check out my talks with Jim Lavelle. I've done a couple podcasts with him. And, he's absolutely on the same page as me with peptides, where they're fantastic. And I definitely think that peptide hormones are the way of the future. But where people get it wrong, especially in social media, is they are medications. So people tell me all the time, well, I'm an expert. I work for Stryker, which is, medical device sales. So I understand the science and I've done my research and I know where to get my peptides. So I don't want to pay a clinic $100 a month in order to get a peptide. I want to get it for $70 a month from this research chemical website. And their research consists of watching YouTube videos and reading articles from non-physician peptide influencers that happen to make their money off commissions from peptide websites. So I don't have to name names, but people know, there's a lot of people out there, these peptide influencers. Yes. And, I think people should be able to do what they want. So if people want to, take a ton of Zins per day and they just want to basically get themselves physiologically dependent on nicotine, then I feel like, they should, but I just want them to know the potential downside to that. And I have seen it go wrong many times. So I've unfortunately seen many people come in with aggressive cancers and they've been on peptides like BPC 157 and growth hormone releasing peptides for, years with no break. And I just don't see how I just don't see a way that those individuals haven't been harmed by that regimen.
Now, when we make it more specific, so are there peptides that you consider recommending when somebody comes in with low testosterone levels as a male, for example, in this case? Is there something that is worthwhile considering before starting TRT, or can you do peptides in parallel to TRT?
It's a great question. They're usually done in parallel, but first, when someone comes in with low testosterone, the question is it high prolactin? Because there's many medications and other things that you can take to lower prolactin, which will then increase testosterone. For example, if they have a pituitary adenoma, which is a small benign tumor, I would not recommend any significant growth hormone releasing peptide because the extra growth hormone is possibly going to grow that tumor. So you want to be very careful with certain peptides. That being said, a lot of times if there's symptoms and the testosterone is not clinically deficient, but let's say that there is a lot of visceral adipose and there's some metabolic syndrome, SHBG, that protein that binds and affects metabolism of testosterone, that's low. So your free testosterone's low, you're not getting good muscle mass gains because total testosterone's low and you don't feel good enough, then often, perhaps a combination of a GLP-1 like semaglutide or tirzepatide or dulaglutide, along with potentially, if IGF-1 is low, a growth hormone releasing peptide like tesamorelin, which is one of my favorite ones, FDA approved for a couple different indications. A combination of those two might improve almost all the symptoms of low testosterone, and then maybe some bremelanotide, which is a melanocyte stimulating peptide. It's very similar to AMSH, which is alpha melanocyte stimulating hormone. Maybe that improves libido and blood flow, nocturnal erections, and maybe something like a low dose of tadalafil as well, which is not a peptide. But a regimen like that might improve all the symptoms, and then over time, the metabolic syndrome improves, and testosterone also improves, and perhaps that individual can avoid the downside of going off and on TRT and get all their symptoms and goals treated in the meantime. And it can be extremely reasonable to do.
So, interestingly, you said the tadalafil as a word, because it gained a lot of traction when the studies came out that people who took tadalafil over a long period of time actually had longevity benefits of it. And this was when I started looking into it, and I've been taking it 5 milligrams probably 5 days a week, most days before workouts. Is that something that, as a doctor, you say this is actually proactive, a good thing to do? What's your stance on this?
In most cases, yes. I think tadalafil, and for the right person, actually dutasteride, that one's a lot more controversial. I think tadalafil is one of our best longevity promoting agents. That's what we're saying now instead of anti-aging agents, but or senolytics. But it is that for a couple of reasons. I do love true functional medicine. And yes, I have the series Dysfunctional Medicine, just talking about the cookie cutter stuff and the wrongs that we see in the industry, just to help minimize these. But true functional medicine is root cause medicine. And as people age, an enzyme called PDE5, which is phosphodiesterase E5, that increases a lot. And that's one of the main enzymes that metabolizes nitric oxide that helps with vasodilation, both for vasodilation if you're trying to get a good workout in the gym, or if you're trying for sexual health. So I think it is reasonable to take low doses of tadalafil to lower that down to what I would consider normal. Mm-hmm. So the older you are, perhaps the higher dose of tadalafil you need. But keep in mind that everything has downsides, including peptides. And we just might not know all of them yet. But the downsides of tadalafil is it does change the intraocular pressure. So if you've had, say, like a lot of detached retinas, then it can change the pressure in the eye. And then it can also lead to reversible color blindness. So for pilots and even artists, a lot of times it is very concerning. Certain types of artists, if someone's a painter, then tadalafil is going to lead to worse quality of work, actually, especially at higher doses. It is dose dependent. And then it can also drop blood pressure. So someone's, doing heavy deadlifts and they feel like they're almost passing out, then they might not want to take their tadalafil before going to the gym that day, because it might lead to them, having a concussion after they pass out on the floor afterwards. So it is important to check blood pressure. It's actually used off-label for small decreases in blood pressure, more so at a 10 mg dose, and it just decreases a little bit. But it is an important potential side effect to consider.
When you speak about side effects, also peptides related, there's a lot of protocols out there that say take it for not more than 6 weeks or not more than 8 weeks. Would you agree with this? And what are the potential risks if you keep on taking them longer?
Yeah, it kind of depends on the peptide. So for your melanocortin receptor agonist, which are bremelanotide, setmelanotide, kind of like your melanotan categories, that is, you're certainly best off not doing it all the time. And if you're predisposed to melanoma, then you might be better off not doing it at all, other than very infrequently, in rare cases if it's not a significant melanoma predisposition, just because it does, stimulate melanocytes. And then with your growth hormone releasing peptides, if you're truly growth hormone deficient, or if you developed an adult growth hormone deficiency, it could be reasonable to take all the time, but you don't have to, because it doesn't shut you down for a long period of time, like a testosterone replacement would be. So many people take these just a few days or several days out of the week, but not every single day. And then for what I consider healing and recovery peptides that do not have a significant muscle building benefit. There's some people who disagree, by the way, but all people who disagree get paid off of their peptide commissions. BPC-157, TB500, which is kind of the same thing as TB4-FRAG, GHK copper peptide, and then the mitochondrial peptides like MOTS-C. These are better off not taking for long periods of time at all, say maybe a month or two on, and then off for a decent amount of time, just partly because of tumor growth risks and also because of unknown side effects that we do not know about.
The last topic, the last question, because you just mentioned mitochondrial, there is this buzz around NAD+, and then when you listen to people, they're like, NAD+ as an IV is actually not as beneficial as injections. And then there's people saying, hey, just take NMN in pill form, then you don't need NAD+. What's the right protocol? What's your opinion? What should you start with? What should you do? Or should you start at all?
Yeah. If your goal is health and longevity, I actually don't think that NAD plus or NMN or NR, I think that it's very overrated as a longevity promoting agent. So again, longevity promoting slash anti-aging slash senolytic, I kind of put all those as just different names. They keep renaming things as they fall out of favor. But anyway, the main goal of them would be if you want an energy boost or potentially a performance boost, or maybe in the case of nicotinamide riboside, a safer form of niacin that's not going to spike your blood glucose and have deleterious cardiovascular disease outcomes data with it. So extended release niacin is generally not used anymore, even though it's proven to increase NAD plus and correct NAD plus deficient myalgias. So the best medical reason to take NAD plus is if you have NAD plus depletion myalgias, which is just muscle aches from NAD plus depletion. So again, back to the analogy of our bodies being organic machines. If you run your car harder, it's going to need more gas. And NAD plus is just one way that you can push gas in. Yes, it needs CoQ10 to convert NAD plus to ATP. But for the right person who's trying to, run hard, then yes, injectable NAD plus or even iontophore's patches of NAD plus or NAD plus IVs are okay as well. Taking those from time to time can give you a good energy boost and relative performance boost, just like topping off or filling up your tank proactively. NMN and NR just take longer to do so. So you can't get behind. So, if you're trying to fill up let's say we're Teslas, or maybe that's a bad analogy because they're out of style now. But anyway, let's just say we're electric cars. NMN and NR are going to take a long time to fill up. That's just plugging your electric car into an outlet, and it takes, days to fill up. Whereas, injections is, a supercharger. So you plug your car into one of those. I don't have an electric car, but the really fast charger, and it's charged up real quick. But you might feel that chest rush. So I do prescribe a lot of subcutaneous NAD plus because life happens and people need to charge from time to time. But a lot of people also feel like they need to pass out or even that they're having a heart attack because there's so much pressure and their heart's racing. So it's important to counsel patients about this before doing something, even like an NAD plus IV. So I think, and then IV is kind of a larger amount of NAD plus, but it's a very different mechanism because you're kind of dripping it in as fast as possible with IV fluids. So it's kind of in and then it's out. Then you actually lose the benefit for a lot of the time. You're probably not going to get an NAD plus IV 3 days a week. So all are reasonable, but just keep in mind what your goal is.
Awesome. Kyle, thank you so much. Can you please share where can people find more about you and learn more?
Definitely. I host the Gillett Health podcast on all platforms. My Instagram's Kyle Gillett MD, and my websites are gilletthealth.com and sagebio.com.
Kyle, this was amazing. I have to admit, I'm probably halfway through the questions, but I'll just keep it for the next episode. Thank you so much.
Thank you.
Thank you, man. Appreciate it.